Hi, I'm Daniel Fein. I'm an assistant professor of medicine at the Albert Einstein College of Medicine and an attending in the Division of Pulmonary Medicine. I'm here today with Kyle Swartz and Randy Rubin, and we're going to talk a little bit about the most common ventilators that you find at Montefiore Medical Center and patient management regarding common scenarios you might find. The outline of our lecture today will be discussing the three types of ventilators. We'll talk about basic troubleshooting, then we'll go through a couple cases. We'll go through a patient with hypoxemia, a patient with ventilatory failure, a patient who's in shock, and then a patient who's ready for their spontaneous breathing trial. Okay, so talking about the most common ventilators we see, this is the Maquette Servo ventilator. Prior to the COVID-19 pandemic, it was the most common type of ventilator that we were generally using both inside and outside of the ICU. The most common ventilator mode that we would use is called PRVC, or Pressure Regulated Volume Control. What happens in this mode is that we set a tidal volume and then we allow the ventilator to select flow based on the patient's compliance to meet that tidal volume. So in this type of ventilator, what you'll see is that there's actually an inspiratory limb and an expiratory limb, so it's a closed system. And this is important during the COVID-19 pandemic in that the expiratory air from the patient is not theoretically going throughout the room. The other type of ventilator we're more commonly seeing now is called an LTV ventilator. The interface is not as robust as the other ventilators, but it's a very capable ventilator when we're frequently using it inside of our ICU. The most common setting that we're using for invasive mechanical ventilation is assist control, which traditionally is a very common type of ventilator mode that we use. And what you do in assist control is you just set a tidal volume, and the patient either can trigger a breath and receive that tidal volume, or the patient is not breathing and the ventilator will deliver that tidal volume by itself. And then the third type of ventilator we're commonly using is called the Philips Respironics V60. Prior to the COVID-19 pandemic, this ventilator was frequently most used for non-invasive ventilation, but now we've employed it for patients who have either tracheostomies or ET tubes in place in what's called the AVAPS mode, and we're finding that it's quite effective. What you do in AVAPS mode is you set a tidal volume, and then you tell the ventilator it could breathe, it could deliver between a pressure of either a minimum or a maximum, and it finds what pressure it has to give in order to deliver that tidal volume. So, when a patient becomes unstable on a ventilator, there are several things that can be going on. One of them is that the patient's primary reason for their illness has become worse. So maybe their ARDS has progressed, or they developed shock in the setting of either COVID pneumonia or any other process going on. And then the other things that could be happening are a problem with the equipment itself. So there's something called the doped mnemonic that you can go through to figure out what exactly is going on and help you troubleshoot the patient. So what to do if a patient is unstable initially on a ventilator? The first thing we should do is call for help. These are commonly complex situations and complex machines. So calling the critical care service and respiratory therapy would be the first thing to do. Secondly, you might want to think about why the patient is decompensating. This might be progression of their acute illness, such as their respiratory failure and ARDS, or the development of shock in the setting of sepsis. There's a mnemonic that you can employ if you remember, or you can look it up at the bedside. DOPES. D is for displaced ET tube. So did the ET tube come out, or is the cuff not fully inflated, or did the cuff rupture? O is for obstruction. So is the tubing obstructed with either mucus or air condensate? Oftentimes this can coincide with high peak pressures, which on the V60 you'll find in the top right corner. On the LTV you'll see there'll be an alarm, and you'll see that in this output window it'll tell you that the pressures are high. And then on the maquette it'll also alarm and show you that the peak pressures are elevated. P is for pneumothorax. Did the patient have a spontaneous pneumothorax? This can be evaluated further with point-of-care ultrasound or with a chest x-ray. Equipment malfunction. Is there a problem with the ventilator? Either the mechanics of the ventilator, the tubing, or the filters? And then S is for stacking, or breath stacking, which commonly occurs most often in patients with obstructive lung disease, where they can't expire, they have development of air trapping, and thus decreased venous return. This is also sometimes termed auto-PEEP. Oftentimes the answer is to disconnect them from the ventilator or slow down their respiratory rate. We should always take caution when we're doing these types of interventions during the COVID-19 pandemic to make sure we're wearing proper personal protective equipment, and that if you're going to apply an ambu bag to a patient, that appropriate viral filter is connected. So let's go through our first case. So our first case involves a problem with oxygenation. A 59-year-old man is admitted to a medical floor with COVID-19 pneumonia requiring a non-rebreather mask. He subsequently deteriorates and requires intubation. He's accepted to the ICU. His ventilator settings are FiO2 of 80%, PEEP of 5, tidal volume 370, and respiratory rate of 10. His oxygen saturation is low at 79%. His heart rate is 101, and his blood pressure is 130/90, with a temperature of 98.5. You find that he awakens to voice and is able to make eye contact, but he looks uncomfortable on the ventilator. And when you put your hand on the patient, he does not seem to be making respiratory efforts that are congruent with ventilator breaths. So the first question is, what should his goal oxygen saturation be? And the second question is, how can we improve oxygenation in this patient? So for goal oxygen saturation, what we generally want to do is shoot for a goal between 92 and 96%. Hyperoxia, or the excess administration of oxygen, can generate reactive oxygen species, which can be harmful to patients. Likewise, shooting too low for an oxygen saturation goal might also lead to complications in terms of ischemia and issues relating to poor peripheral oxygenation. So how do we improve oxygenation in patients on ventilators? Well, the first thing we should do is administer further PEEP to this patient. Patients with ARDS, particularly COVID pneumonia, seem to be particularly responsive to PEEP. So how can we improve oxygenation? Well, the two ways to improve oxygenation for a patient on a ventilator is either to increase the FiO2 concentration or increase the PEEP. The way to do this on the maquette servo ventilator, to increase the PEEP, is simply to go to the output where it says PEEP and then turn the dial upwards. So if you want to increase the PEEP to 10, you just turn it to 10 and the PEEP is at 10. To increase the FiO2, you do the same motion where you just increase, you turn the knob until you achieve the fractional concentration of oxygen that you desire. On the LTV ventilator, to increase the PEEP, you go to the bottom right here where it says PEEP, you press, you toggle, and then you press again. Similarly, to increase the FiO2, you press, toggle, and then press again. On the V60, you would find the EPAP, which is analogous to PEEP on this ventilator. Press this button several times and then click accept. And now your PEEP is actually set at 10. Similarly with the FiO2, you can press the arrow and then hit accept. And now your FiO2 is also increased. For titrating PEEP and FiO2, we should generally be following the either low or high PEEP tables from the ARMOR trial, which are readily available either in the Pulmonary protocols on the Department of Medicine website or searchable online. Oxygenation and PEEP, we want to increase PEEP first because it's thought that COVID-19 patients are particularly responsive to PEEP. And what you want to do is always try and be somewhere near one of these boxes. So if a patient is on 80% FiO2, their PEEP should be at least 14. It's thought that possibly it should be even higher and correlating with what is called a higher PEEP table. However, outside of an intensive care unit, we might want to use caution. This is the low PEEP table from the ARMOR trial, the ARDNET study looking at low tidal volume ventilation. Generally, when you're titrating PEEP and FiO2, you want to try and be in one of these boxes. There's also a high PEEP table, which for a designated amount of FiO2 will just put you in an area where you're getting even higher PEEP. In general, if you're in either the low or the high PEEP table, you should be in good shape with your ventilator settings for appropriate use of PEEP and FiO2. So besides titrating PEEP, you could of course increase FiO2 in your patient. Additionally, to improve oxygenation, what you might consider doing is repositioning your patient. Patients with ARDS, particularly COVID-19 ARDS, seem to respond particularly well to prone positioning, either when they're intubated or not. This may or may not be feasible on the medical floor, depending on your resources. The other thing to do if a patient is not synchronous with the ventilator and they're intubated is to increase sedation. This doesn't always work, but sometimes serves to improve oxygenation. If you're able, you can additionally attempt to administer paralysis, though this might not be within the scope of care for a patient outside of the ICU. So what about a patient who has issues with ventilation? Let's talk about a 77-year-old woman with a history of COPD who's admitted to the medical floor with COVID-19 pneumonia. She's subsequently intubated. Her ventilator settings are an FiO2 of 40%, PEEP of 5, tidal volume of 350, and respiratory rate of 12. You get an arterial blood gas, the results of which are a pH of 6.9, a PCO2 of 95, a PO2 of 76, and a bicarbonate of 24. Her vital signs are a saturation 98%, heart rate 118, blood pressure 130/90, temperature 97.5. She awakens to voice and is able to make eye contact. You put your hand on her chest and note that she seems to be synchronous with the ventilator. So what is the interpretation of the blood gas? So the pH of 6.9 implies an acidemia, and then the elevated PCO2 implies an acute respiratory acidosis. So what can you do to improve the findings on this blood gas? And let me say that with the caveat that not all blood gases need to be fixed. Oftentimes, patients are quite tolerant of respiratory acidosis, and there's even a thought that there's something called permissive hypercapnia, or whereby hypercapnia might be in some way physiologically protective. In this case, though, they do have quite a profound respiratory acidosis, and what you'd want to do is increase the minute ventilation of the patient in order to blow off CO2, and thus likely improve the pH to a more acceptable level. So, what you can do to increase minute ventilation is either increase respiratory rate or increase tidal volume. Generally, we're much more likely to increase respiratory rate because it's been found over and over again that high tidal volumes are injurious to patients, resulting in acute lung injury, release of inflammatory mediators, and worse organ failures and outcomes. With respiratory acidosis, what we want to do is increase the minute ventilation. And the safest way to do that for patients is to increase the respiratory rate. Increasing tidal volume can lead to acute lung injury and likely worse outcomes for patients. So as long as the patient is not profoundly obstructed, what you want to do is increase respiratory rate. On the maquette servo ventilator, all you have to do is toggle the knob under respiratory rate to the right. So if I want to increase to 18, I just toggle and leave it there. For the LTV ventilator, all I do is go to breath rate, click once, toggle, and then click again. For the V60 ventilator, you just go to rate, hit the arrow several times, press accept, and now your rate is increased, thus hopefully compensating better for your respiratory acidosis. Additional things that have been done and advocated for at times are administration of bicarbonate or increased tidal volumes. But as we talked about, at least increased tidal volumes are not advocated for, and administration of bicarbonate often leads to fluids, which is generally thought to be injurious in patients with ARDS. So the primary thing to do would be to increase the respiratory rate. The only thing to be mindful of is the fact that oftentimes in patients with obstructive lung physiology, you can get air trapping and decreased venous return, which can cause hypotension and hemodynamic instability. For ventilatory failure as well, at times increasing sedation can increase synchrony and lung mechanics. And so this can be an option as well. Another option in addition would be if a patient is obstructed, if they're wheezing and they have true airways exacerbation, you can administer bronchodilators and steroids. The next case is a patient with shock. So a 45-year-old woman with morbid obesity and sleep apnea is admitted for COVID-19 pneumonia complicated by acute respiratory failure requiring intubation outside of the ICU. So she's on 80% oxygen, PEEP of 20, tidal volume of 350, and respiratory rate of 18. Her oxygen saturation is normal, or even supratherapeutic, but her heart rate is 142 and blood pressure is 70/40. She seems to have a low-grade fever. She's intubated and sedated, and she's also diaphoretic. So what could be the differential diagnosis for this patient's hypotension and shock? So the first thing we want to think about in a patient with very high PEEP is that PEEP causes increased intrathoracic pressure, thus decreasing venous return, additionally compressing the pulmonary vasculature, and subsequently possibly putting a lot of pressure on the right ventricle. Sometimes in the ICU what we do is we actually do a point-of-care echocardiogram and we can see if the right ventricle looks over-distended, whereby it's at least bigger than the size of the left ventricle. We often don't have this luxury in patients outside of the ICU or where an ultrasound isn't available. So the first thing you'd want to do is possibly, if the patient can tolerate it from an oxygenation standpoint, would be to lower the PEEP. The other thing to do until help arrives would be to start peripheral vasopressors, because the alternative to the fact that possibly the PEEP is too high and that her lungs are hyperinflated, decreasing venous return, is that her shock is simply worse due to COVID-19 pneumonia, which is a common phenomenon that we're seeing. So starting peripheral norepinephrine if you don't have central access is a reasonable temporizing measure until further help arrives. The caveat to this being that it should be through a 20 gauge IV in either the forearm or upper arm, not in the antecubital fossa, and that this should not be a long-term strategy, only until further expert advice is available. So for this patient, what steps can we take immediately to mitigate their current hypotension? Well, we know that PEEP that's elevated can potentially decrease venous return and also decrease compliance in the pulmonary vasculature, thus leading to the right ventricular overdistension. So what we can immediately do, as long as their oxygenation tolerates, is go down on the PEEP. And in the maquette servo ventilator, you simply toggle to the left. Let's say we turn it down to 12. On the LTV ventilator, similarly, you click, toggle, and then click again, thus decreasing the PEEP. And then on the V60, we look at EPAP, click it, click the arrow several times, and then accept. Lastly, let's talk about a patient who might be ready for a spontaneous breathing trial. A 49-year-old man is admitted 7 days prior with COVID-19 pneumonia. He's clinically improved overall and seems like he might be ready to be evaluated to be removed from the ventilator. So what are the criteria for putting the patient on a spontaneous breathing trial, and what are the criteria for passing a spontaneous breathing trial? So what you want to consider before putting a patient on a spontaneous breathing trial, you want to think about if they've reversed the cause of respiratory failure, if they're awake and following commands, and oftentimes we ask patients to lift their head off the bed. Do they have minimal secretions and an adequate cough to clear any secretions? Are they on minimal oxygen support? Is their pH fairly normal? And are they hemodynamically stable, meaning are they on no or very low doses of vasopressor medications? If you deem that a patient by these criteria is ready for a spontaneous breathing trial, what you then want to do is put them on a spontaneous breathing trial for between 30 and 120 minutes. Generally, we do spontaneous breathing trials on CPAP or PEEP of 5 and pressure support of between 5 and 8. And then you assess for tolerance of the spontaneous breathing trial based on the criteria listed, such as oxygenation, whether their minute ventilation is adequate, whether their respiratory rate is appropriate, and making sure that there's no respiratory distress as measured by these criteria. So on the ventilators themselves, to change the patient to a spontaneous breathing trial, on the maquette servo, you go from PRVC to pressure support setting. The way you do that is you press up here, you hit PRVC again, then you go to pressure support CPAP, and then the two most important numbers are the PEEP and the pressure support above PEEP. So generally, we would want a patient on a spontaneous breathing trial to have a PEEP of about 5. And pressure support above PEEP somewhere between 5 and 8. So we'll give this patient 8. So right now, this patient is on a PEEP of 5 and pressure support of 8. And there should be a backup rate if they continue to be apneic. Put a patient on pressure support on the LTV ventilator. You need to change to pressure mode, change to CPAP. You hit each button twice, and then you put the patient down to a breath rate of 0. So now they're just getting pressure support at 8 with a PEEP above 12. So then, of course, if we want to put them on pressure support 8, a PEEP of 5, you'd have to turn this down to 5 as well. And there is a backup rate, so the ventilator should alarm eventually. If you want to put a patient on pressure support, what you want to do is go to what's called ST mode. You hit modes, ST, and then you set the patient to the PEEP that you want, which would be 5, and augmented inspiratory pressure that you want. So perhaps that would be 5 as well. Then you hit activate ST mode, and now your patient is on a pressure support of 5 with a PEEP of 5 for a spontaneous breathing trial. So in summary, in order to improve oxygenation, what we can do is either increase PEEP according to our Argonaute table, or increase the FiO2. When we increase PEEP, we want to be very mindful of increased intrathoracic pressure and RV overdistension, which may cause hypotension. And so patients should be closely monitored and expert advice should be obtained. In patients with ventilatory failure, respiratory acidosis, one thing we can do is increase the respiratory rate. We should almost never increase tidal volumes in patients, as this can be injurious to the lung. You want to be mindful, even when you increase respiratory rate, that hyperventilation can cause breath stacking and also cause impaired venous return in some patients who have obstructive physiology, such as COPD and asthma. For patients with shock, if they have acute hypotension, you can attempt to decrease the PEEP, which might improve their blood pressure, but also have a low threshold if a patient is truly sick for starting vasopressors, which can be done peripherally as a temporizing measure. But, of course, obtaining immediate help would be advised. And then, of course, have a low threshold to do spontaneous breathing trials on patients every single day that they're intubated. They should always be assessed every single day. And for further information on this, you can look at the slides from this lecture, as well as the pulmonary protocol listed on the Department of Medicine's website. Thank you for your time.